All right. Well, thank you for joining us on today's webinar. We'll get started here in just a couple of minutes. Please, for now, locate your chat box on the bottom of your screen. Let us know where you're logging in from. Please note that today we're in Zoom's webinar platform mode, and that means as attendees, your camera and microphone are disabled. So the only way you can interact with our panelists today is through the chat box feature. You'll be able to see and hear the panelists, but they won't see and hear you. So sit tight for a few minutes. Let us know where you're logging in from, and we'll get started here in just a moment. Like we've got some folks from Alabama and Colorado, California, South Carolina. Welcome, we appreciate that. Indiana, San Francisco, Lexington, Louisville, all places, Pikeville to Paducah, and all places in between. Someone from Massachusetts, or Boston, wonderful. Great, thank you all so much for joining us. All right, well, we'll go ahead and get started. Welcome again, and thank you for joining today's webinar entitled Public Health in the Time of COVID-19. My name is Jack Galt. I'm with the UK Alumni Association. And today's session is part of our Great Teachers on Great Challenges virtual speaker series that's co-sponsored by the UK Alumni Association as well as the Provost Center for the Enhancement of Learning and Teaching. The series will regularly conduct conversations with UK faculty who have won the UK Alumni Association's Great Teacher Award, the oldest continuously given award for teachers at UK. First, let me introduce my co-host for today's webinar. Trey Knatzer is the Associate Director for the UK Center for the Enhancement of Learning and Teaching. Trey will be assisting us with the Q&A portion of the webinar a little bit later, towards the end. You're welcome to submit comments and questions in the chat box throughout the webinar, but I believe the panel will wait and take most of those at the very end. Please note that you have an option of submitting your comments or questions to all panelists and attendees for everybody to see, or if you just want to submit it to the panelists, that's fine. Or if you just want to say hello to one of the panelists or another attendee, you can do that as well. So appreciate that. And now I'd like to introduce the moderator of today's program, Dr. Martha Riddell. Dr. Riddell is a 2020 recipient of the Great Teacher Award at UK, an associate professor in health management and policy in the College of Public Health. She is also the director of the college's Master of Health Administration program. Martha?
Thank you, Jack. Thank you, Trey. Let me first start by thanking the Alumni Association and the Provost Office for making this series possible. Thank you both very much for your contributions. As Jack said, today we're focusing on public health and the COVID-19 pandemic. There are many people in UK's College of Public Health who are working on initiatives around the pandemic and helping to address the issues around COVID-19. Today, we are going to feature, and you will hear, 4 of our faculty members who are really working on the front lines addressing the pandemic. They have great things to share. They are all working on impacting evolving world issues in real time. And so I'm excited to hear them myself. Remember, as we go along, we are going to hold all the questions until the end, but go ahead and use that chat feature so that you can go ahead and ask questions as we go along. Dr. Kathleen Winter is our first speaker. She is an assistant professor of epidemiology, and that's a word I'm sure you've heard more in the last 4 months than you had in a long time before that. She is in our College of Public Health. Before she joined our faculty, she was a supervising epidemiologist in the immunization branch at the California Department of Health for 10 years. And she is now with the Lexington-Fayette County Health Department working on their responses to COVID-19. Welcome, Kathleen.
Thank you very much. I'm going to go ahead and share my screen so you can see my slides. Can you see?
Yes.
Great. Well, it's a pleasure to talk with all of you today. I don't have a lot of time, so I'm going to try to fly through a fair amount of material quickly, and we can save some time for questions as well. So I want to start out with some basic principles of infectious disease transmission and discuss a little bit about droplet and airborne transmission. When we talk about droplets, we're describing these secretions that come from the nose or throat that are spread through coughing and sneezing or even just talking or breathing. And they usually don't travel much further than 3 feet. They're heavy and they can fall to the ground or fall to different surfaces. And viruses and bacteria can be present in these droplets, and people can be directly exposed to those droplets if they enter their eyes or their nose or their mouth, or they can be indirectly exposed if somebody touches a surface and then they put that organism into their eyes that way. Aerosols are smaller and they're formed from evaporated droplet nuclei. They can remain suspended in the air for some period of time and be inspired by somebody who's not that close to the source. So we know that droplet transmission is the primary mode of transmission for COVID-19, but we also can't rule out the possibility that some airborne transmission is also occurring. So the current data on COVID-19 is that it's about 2 to 3 times more infectious than influenza. And we know that there's a high level of viral shedding or in the upper respiratory tract of people who are infected. So this is different than what we saw with SARS and MERS, where people had viral shedding in their lower respiratory tract. So there just wasn't quite as much transmission as we see with COVID-19. There's good evidence that asymptomatic transmission occurs. There's viral loads, and asymptomatic patients are similar to those in patients who have symptoms. And we've also got evidence that viral loads are highest early on in the course of illness, and that includes those few days prior to symptom onset. So even in people that are in this pre-symptomatic period before they become sick, they can have high viral loads and be infectious. Super spreading has been documented with COVID-19, and this is when one individual transmits to large numbers of individuals. This is a phenomenon that's common among infectious diseases, and it can be the result of somebody who is just extremely infectious for whatever reason, whether it's an immune response or some other reason, or they have large numbers of contacts, or both of those things. There's one study that was recently published showing that in a choir in Washington State, one infectious person was shown to have transmitted to 52 out of the 61 attendees to a choir practice. And we've got pretty good evidence that the virus can be found away from patients. This is either in ventilation systems, in the air, or located in hallways, on floors, or in surfaces. So we know that transmission can occur away from the source. But when we talk about viral shedding, we need to make the distinction that it's not the same as infectivity. When we do these studies, we're usually looking for presence of the genetic material of the virus, and it doesn't necessarily mean that you're detecting living or viable virus. So it's a little bit difficult to always understand exactly how transmission is occurring. The reason it's so important to understand transmission is because it informs what we need to use for protection. So the preferred protection for airborne transmissible diseases includes eye protection, which is a face shield or goggles, a gown and gloves, and an N95 respirator. And the N95 must be fit tested, which means that it's shown that it fits tightly to the face and filters out air that is inspired by the person who is wearing it. So the air that they are breathing in is filtered through the respirator. This is different than a surgical mask or a procedural mask because those are looser fitting. And so when somebody breathes in, they're not breathing in only filtered air. So surgical masks can be used as protection against droplets or coughs or sneezes to the face, but they do not protect against inspired air that might be contaminated. These cloth face coverings, these homemade masks, they are not considered PPE. There's not good data to show how effective these are, if they are effective at all, at protecting the wearer from exposures. However, there is good growing evidence that they do help contain droplets from the person who is wearing them. So how do we go about stopping an outbreak? This is actually a slide that I've used in my infectious disease epidemiology class long before Dr. Fauci became a modern celebrity. But he describes these three classic public health measures, and that includes disease surveillance, case identification and isolation, and contact tracing and quarantine of those contacts. And we know that these are the three elements that we must really capitalize on to make a difference in controlling disease spread. But of course, it depends on the ability to test large numbers of individuals and identify those cases quickly, place them in isolation, and then sort out who their contacts are and track them down. And this idea of contact tracing has really become very popular, and everyone now is understanding this concept of what this is. It's nothing new to public health. We've been using contact tracing for decades, and it's important to note that what's required for contact tracing to be effective is that individuals are not just notified of their potential exposures, but that they take action and they self-quarantine so that they do not continue to spread. And I think that that's one piece that people kind of forget, that, you know, we have all these new technologies we can use to try to sort out who was in close proximity to a case. But unless that individual is able to stay home from work and self-isolate from others in their home, then there will not be very much impact of that contact tracing on reducing disease transmission. So my last slide, I want to talk a little about herd immunity. And herd immunity is this idea that there's a population level threshold that is needed in order to help reduce disease transmission within the community. And there's different herd immunity thresholds for different infectious diseases depending on how infectious those pathogens are. We don't yet know what the herd immunity threshold needs to be for COVID-19, though some studies have estimated it needs to be somewhere around 70% to prevent ongoing transmission. Now, we do know that we are well below that threshold now in the United States. We don't know exactly what proportion of individuals have been infected, but we know it's well below this number. And so we expect to see ongoing transmission occurring within a community until we have protective levels of individuals who are immune, either through disease, prior infection, or through vaccine. All right, I'm going to stop there since I think I'm at the end of my time, and I look forward to hearing the rest of the presentations. Thank you.
Thank you, Kathleen. Let me remind you all to go ahead and put some questions in chat so that we can tee them up for Kathleen after all the presenters have spoken. Our next presenter is Dr. Teresa Waters, who holds the Charles T. Wethington Jr. Endowed Chair in the Health Sciences and is also chair of the Health Department, Department of Health Management and Policy in the College of Public Health, and also serves as the Associate Dean of Research. Her topic's a little different because she's going to talk about building a model to help individuals and organizations plan for the future around COVID-19. So welcome, Teresa.
Thanks, Martha. All right, so I'm going to share my screen as well. Can't have presenters without slides. Okay. There we go. So thanks. I just want to spend a few minutes talking about COVID-19 modeling, and in particular about our health system preparedness in relation to that modeling. As COVID-19 was beginning to rage in March, several groups were reaching out for expertise in the area. I am definitely not an infectious disease epidemiologist, but was somewhat knowledgeable about health systems and preparedness, and so joined these teams. There were other College of Public Health faculty who were on these teams, one from the healthcare system and one from the state, and notably, Donna Arnett was involved as an epidemiologist. So it really did take a group of us looking at some of these issues, and the one team that I'm still working on is with the Cabinet for Health and Family Services as they're continuing to model. So let's just talk a little bit about this. Why modeling? Well, initially there was tremendous uncertainty about the spread of COVID-19 and worrying about the resources that would be required to treat patients. A lot of the models that were out in early March made some really dire predictions about how many infections we would have, hospitalizations, and deaths. And I know that we all remember very well the horrifying footage from Wuhan, Italy, and then later New York, where hospitals were just overrun. And especially in Kentucky, we were very worried that given the poor health status of many of our citizens, that we would be challenged to have enough capacity, especially related to ICUs and ventilators. Uh-oh, there we go. So here is an example of a model that we were looking at in late March. And you can see that there's a couple things that I would point out to you. We modeled a lot based on hospitalizations and deaths because testing was so low, that testing was really not telling us how many people were infected. In Kentucky, the anchor date, the first hospitalization from community-acquired COVID-19 was March 6th. This particular model that I'm showing you here was done at the end of March. And at that point, we were predicting the peak in hospitalizations, that gray hump, would be around the middle of June, right about now. And we predicted, based on those early models, that we would have 6,300 patients in hospitals due to COVID-19 at that point in June. And that 1,600 of them would be in ICU beds and 1,000 of them would be on ventilators. And that's in addition to the patients who normally occupy our hospital beds, our ICU beds. And so there was a lot of concern that we would not have the capacity to handle all the cases and provide adequate health care. But here's what actually happened. The peak was earlier and much lower than we anticipated in those early models. In fact, we sort of had this mush of a peak between the end of April and the end of May, and it peaked at about 700. That means 700 beds in Kentucky were occupied with patients from COVID-19, much less than what we had expected. So I get asked this almost daily, were the models wrong? And the answer is yes and no. Essentially, all models are wrong because they are based on projections and estimations. But as George Box, a very famous statistician from Great Britain, said, essentially all models are wrong, but some are useful. So what are the models doing? They're trying to deal with a lot of uncertainty. Many of you probably saw on the news, flatten the curve, flatten the curve. And that was really to try to take what is essentially many of the same cases, we thought, but stop the peak from being so quick and so high, sort of mush it down so that we would have enough healthcare capacity, which necessarily meant that this would be a much longer phenomenon. So we really didn't know exactly how to get there, but we knew we wanted to flatten the curve. And so we implemented a number of measures. We called them social distancing. We knew that social distancing, strong actions of social distancing could really push the curve down. We didn't know by how much, and that weaker measures would not push it down as far. But in essence, the modeling isn't about accurately predicting the future, because things are constantly changing and we are making different decisions. So I like to think about models as pruning the possibilities, offering the possibilities and figuring out which ones we definitely don't want to happen. Here I've made a little decision tree where there are 4 possible scenarios, 4 possible preventive measures that we could take. We could take none, we could take mild, moderate, or strong. And each of those choices has very real consequences for deaths, hospitalizations, across them. And as you see, this is definitely a scenario that we need to avoid. And in many ways we have. We implemented very strong shelter-in-place orders, And in essence, what we did is we pruned out that possibility. So now we can look at some scenarios and choose among some better scenarios. None of them are great. And so the non-response, do nothing, is a scenario that we have avoided. And it seems like we've done a really great job, especially in Kentucky. We did not overrun the hospitals, and hospitalizations have been on the decline. But is it over? Not even close. We know there was a major impact of shelter-in-place orders and to a lesser extent, business closures. But we have a lot less information about these intermediate measures that we are now moving to. And we do know that by moving away from these strong measures, shelter in place, we are going to see higher infection rates and more hospitalizations. And the question is, how much higher? And there will be some resurgence. And in some cases, in some areas where the infection grows very rapidly, we may need to consider moving back to more strict measures. So I'm going to end there, stop sharing my screen, and hand it back to Martha. You need to unmute yourself.
Thank you very much. Very interesting information. I'm sure we'll get some questions in that chat box. So go ahead and send those in, please. Now, our next speaker is Dr. Keith Knapp. Dr. Knapp is an associate professor in the Health Management and Policy Department, and he is a longtime leader in long-term care. He's now serving as senior advisor on adult populations for the Office of the Secretary in the Cabinet for Health and Human Services in Frankfurt these days, and doing a lot to support and initiate actions around long-term care settings in a very vulnerable population. So he's going to share with us today. Welcome, Keith.
Glad to be here with you. Thanks, everyone, for tuning in today. Here we go. All right. I recognize some of the names of people who have logged in, and I know that you know what I mean by a rumble seat. That's something that's very popular with our residents whose average age is 84, from the cars of the 30s and 40s, where you kind of rode outside and behind everybody else, and it was a thrill on a nice day and not such a thrill on the not so nice day. And you'll see why in a minute I use that metaphor to describe what's been going on in long-term care during this pandemic. Let's see, I'm having a little trouble advancing. It's the trick, Jack.
Click on your slide. There you go.
Okay. So the realm of long-term care, a lot of people who aren't in that space all the time because of a family member or a church member or a neighbor, think of the old nursing home, and it's really expanded considerably in the last 20 years, even more so in the last 10. And so I've just listed all the different terms that are used in different states to describe in declining complexity of the people that they serve. Skilled nursing facility is the most intense, the people with the most medical complexity. And then moving on down that list, there are lots of commonalities with what we do in skilled nursing care and nursing homes, in intermediate care facilities for individuals with intellectual disabilities. They have slightly different needs, but a lot of the services meet their needs very nicely. And so for the purposes of this discussion, they're in the same club with the old folks. Personal care homes and assisted living communities in Kentucky are kind of a bifurcated assisted living. Most other states call both of those assisted living. Personal care homes are kind of, in our state, skilled nursing light, if you will. And then family care group homes are the next level down. And then congregate independent living can be either what you think of like a continuing care retirement community or senior housing, high rise, Section 202. And then the newcomer really to the whole spectrum of this continuum is the most rapidly growing segment of long-term care, and that's home and community-based services, home health, hospice, adult day centers, and other kinds of supports and services. And we'll come back to that in just a minute. So there are folks in the gerontology world that have kind of borrowed the Latin root, GER, to describe COVID-19 as a tailor-made gerocidal agent. And that's a pretty accurate description, and I'll give you some of the numbers that make me say that. We know that when we risk stratify, the various things we know contribute to the people who are most vulnerable, that they are living in long-term care facilities. Age matters a lot here in Kentucky. Thus far, in the 3 months, almost 4 months we've been tracking this, the mortality risk actually doubles for every decade after 60. Let me say that again. Your risk of dying from this disease at 70 is twice as great as it is at 60 and twice as great at 80 as it was at 70. And those are the numbers. In fact, 70 plus, although it only represents 11% of our population in Kentucky and only 16% of the cases, accounts for 75%, 3/4 of the deaths we've had so far in Kentucky. So there are reasons for this. You know, when you get older, you have multiple comorbidities, and Kentucky has got a bad looking list on those comorbidities, and we've known that for some time, but it really targets the folks who have this in spades. So hypertension, diabetes and or kidney disease, obesity. See a lot of this all in Kentucky. And then, of course, compromised respiratory from either a lifetime of smoking and COPD or other reasons, all leading to some sort of immune system compromise. We've also learned, and you can probably track this in the governor's press conferences, that there's a disproportionate share of African Americans that for some reason have bad outcomes from contracting this disease, and they get it more frequently. We don't know the why just yet, but that has had an impact, oddly enough, in the long-term care community, more on the staff side than the resident side of how profound this impact has been. So you think about it, it's a perfect environment for a little environment like the coronavirus, where you've got a lot of people living in a small amount of space and they're interacting on a regular basis. The hallway width in most of the designs of the older nursing homes and long-term care facilities is narrow. You might rely on elevators for the number and size of the building, and the buttons and doorknobs and other stuff you got to touch just to get through the place. Pass each other on the entrances and exits. And one of the learnings that I'm hoping will be a public policy outcome of this whole affair is the death knell of semi-private rooms or shared bathrooms. A lot of the buildings that were constructed in the 60s and 70s have this design component. And we now know that it's, although that was done largely for reimbursement purposes, we now know that in order to battle something like this pandemic, that is just a recipe for a disaster. And a lot of what's gone badly has been a result of people having to share space that closely. And then the real honeybees going flower to flower are everybody who's coming in and out of the building. And our state did a pretty darn good job compared to others about deciding to shut the doors early. And that has proven to be a good strategy in terms of outcomes. We're on every measure on a per capita basis are outperforming the 7 states that surround us, and the kind of in the middle of the pack on a national level, whereas usually when there's a list about healthcare, we're in the bottom 5 of everything. And we're doing much better than that with respect to how it's going in the long-term care facilities. Comparatively, somebody earlier said something about it, none of it's good. I think it might have been Teresa. We're trying real hard to make it less bad than it might have been. Our long-term care facilities that have at least one case is about half of them. And there's only one county left in Kentucky out of its 120 that doesn't have at least one. We got 2,300 resident cases, resulting in 338 deaths. And these are numbers through yesterday. So this is very current information. And then you see there staff cases and deaths. So you put that together, our staff and residents that are living and or working in that environment represent 25% of the cases we've had thus far in Kentucky, but 66% of the deaths. So that is a really profound epidemiological challenge. And a little bit of my space to even claim that, but I know that the epidemiologists I've had a good portion of working with at the cabinet in the Kentucky Department of Public Health and the local health departments, like we heard Kathleen earlier, it's pretty easy to identify that's where it's going on, but it's because they're the most vulnerable and we've got them living together. So what are we going to do about that? Well, this isn't the solution, but it is an underlying problem from a public policy standpoint. That's why I'm raising it. Our culture suffers still from an underlying limitation attitudinally about aging. And ageism plays a key role when we claim politely at a party or when we're having a conversation about it that we have these kinds of values when it comes to our elders: honor, respect, dignity, gratitude. We want to protect them and value their history. When the lived experience in American contemporary culture is that we're afraid of aging, afraid of growing old ourselves. We see in that person something that we don't want to see for ourselves necessarily, and tend to even have the opposing almost antonyms for the first list with it's a burden, to others in the family. We make jokes about, go to the Hallmark store and go to the birthday card section. We make wisecracks about, you put another year on, but better call the fire department, we're gonna have to blow out all those candles. Anyway, we fear it, we resent it. So we do what? We separate folks, and that's not new, but it has persisted, and it's really highlighted during the pandemic what a bad idea that probably is, unless we decide to do it a lot differently. So during the pandemic, there's really been exposed a hierarchy that everybody was kind of aware of already, but when it comes to scarce resources like the things I've listed here, the hospitals come first because that's considered to be the most urgent. And you heard Teresa talking about how we anticipated being overrun, and that just never developed. Well, while we were anticipating that, the nursing home community was really begging, riding in the rumble seat with respect to getting adequate personal protective equipment, having enough testing kits to do universal testing, having enough staff that even when you did the testing and you found out you had 19 asymptomatic staff members that you had to send home, where's their replacement? And then hospital preserving its surge capacity didn't really die down until about a month ago. So now that's all gotten a little bit better, but the delay has been expensive in terms of human cost. For the state's role, I got to brag on our Cabinet for Health and Family Services a little bit. The Medicaid support for the provider community taking on these extra responsibilities has been better than most. It's still scarce dollars because we have also added we're up to 1.47 million people on Medicaid in Kentucky now because of them having also been eligible to apply for unemployment insurance. So that's 1/3 of the Kentucky population that's in the Medicaid program right now. So it's even more scarce resource than general. Our Office of Inspector General has been a lot more collaborative than many other states in working with the provider community to make sure we get good outcomes instead of in some states like Michigan and New York, you hear of them just even getting tougher on the provider community, almost kicking them while they're down. And our Department of Aging and Independent Living has been a great source of support for our assisted living and adult day centers and intellectual disabilities community. And of course, our public health department, both state and local level, worked amazingly cooperatively, kind of circled the wagons and did the best job possible. So what's on the horizon? There's this ethical tension between keeping people safe That's always at the higher end of an ethical panel. But now we kind of thrown away the key for 3 months in learning about the tolls of isolation for the residents and their families. And there's a lot of saber rattling going on about when are we going to open up? When's it safe to open up? Well, those two things are very different questions. And so we're trying to find a plausible balance in the middle. And so what you can do for a family member, neighbor, former neighbor, someone you happen to know that's in this predicament is write a good old-fashioned letter, U.S. postage. I know we're doing some other creative things with FaceTime and doing some lifetime visitation, but 84 is the average age of a person living in a nursing home. They like letters. They love photos with those letters. So that's something that everybody can do, and I would encourage you to do it. There's been some pretty creative folks in the provider community trying to offer ways to do window visits. It's a little tough to do in a high rise, but if it's a 1-floor building, you can do it pretty easily and figure out other ways to connect with people who are feeling disconnected from the people that matter in their lives. So one of the big questions I get from family members is, so with the survey teams not going in there and nobody really watching what's going on, what if I've got some concern about that person I have living in a nursing home? And so I don't know, I'm guessing people will have access to these slides after today, but there is the toll-free number for our state's long-term care ombudsman program. And they are the first line of defense for somebody who is questioning whether the right things are happening. And next for us is tackling this issue I just raised about how do we balance resumption of social interaction and small group activities, congregate dining, and limited visitation, and make sure that we take every precaution that is reasonably possible to keep people from spreading disease. Because one of the curious things about the coronavirus is that so many folks are asymptomatic and feel fine and will tell you they feel fine, but they're carrying the virus. And so introducing those people into that environment is probably not in their best interest. So let me just wrap up by thinking in the future, because this is all retrospective, I think there's some great opportunities for our students in the short term with the explosion of the demand for contact tracing as a first job out of college kind of thing, much less for if your public health career gets started that way, get some healthcare experience. We're just obviously hungering for new leadership in the whole field of healthcare, but especially in long-term care, and make a real contribution. And then the research opportunities are magnificent along all the lines I've listed here. The one that I think is going to be, I saw one of the incoming questions asked about the shutdown of the economy, is the impact of this kind of thing in the bigger picture. And how do we learn from what we've experienced here to not do the same way next time, or what do we need to do earlier? And then of course in my space, the whole realm of health and aging policy is going to be wrought with opportunity for how can we do this better to be better prepared, not if, but when this happens again. I went 10 minutes, apologize. Thanks.
Thank you, Keith. That's lots of good information. Our next speaker is our Dean, Dr. Donna Arnett, who's Dean of the College of Public Health. And she's also a professor of epidemiology. She's past president of the American Heart Association, and she's also a member of the National Heart, Lung, and Blood Institute's Advisory Council. I know that, Dean Arnett, you've been involved in multiple initiatives around COVID-19, and we're very honored that you are with us today to share some of your thoughts and insights. So welcome, Dr. Arnett.
Well, thank you. Can you see my screen?
Yes.
Oh, good. I wasn't sure. Keith I didn't want to cut Keith off, so thank you. And thank you for the invitation today, Martha. This is such an incredibly important area for our college. And I'm going to discuss the population disparities in COVID-19, what we think the challenges and causes are of that, and then potential solutions. So we observed early on in this pandemic that there are truly large racial ethnic minority differences that have been observed both in infection rates, but also severity of illness. And really, this pandemic has become a magnifying glass that highlights the significant racial and ethnic disparities in health and healthcare in our country. And it really is a call to action for us to think through how we serve our communities equally. So we know also prior work from the CDC suggests that African Americans have this greater risk of contracting COVID-19. But what's amazing is the result in terms of mortality. So they have a 6-fold greater mortality rate from COVID-19 than their white counterparts. And a recent study from Emory University that was recently highlighted by the director of NIH and the director of the National Institutes on Minority Health and Health Disparities, Dr. Eliseo Pérez-Stable, focused on the large number of cases that were coming from populations that were primarily African American. So in Dr. Pérez-Stable's analysis, they looked at the counties that were disproportionately Black. So 22% of the counties that are disproportionately Black in our entire country generated 52% of the COVID-19 cases, and more importantly, 58% of the deaths. So it was a large ecologic study, but it really points to these tremendous health disparities, primarily in African Americans. So Keith has already highlighted what's going on in Kentucky. These are data as of the end of May in Kentucky of the distribution of race and ethnicity by population. And so you'll see here, African Americans are the second down. So they represent 8% of our Kentucky population, 15% of our cases, and 18% of our deaths. So even though they're only 8%, it's almost 1 in 5 deaths are happening amongst our African Americans. So really right now is a call to action for us to redouble our efforts to really understand how we can enable strategies to stop this epidemic or pandemic of health inequities. So Keith has alluded to some of the causes of why are there these disparities. And first and foremost, we know that there are systemic inequities in healthcare. So what does that mean? It means that African Americans are more likely to be underinsured or uninsured in our population. We also have a system of segregated healthcare. So it's really difficult to have access to primary or specialty care in urban poor settings and rural settings as well. We also know that COVID-19 testing has been mostly performed in the more affluent areas, which tend to be white, rather than in the poorer settings where there are more minorities living. We also know that we have an embedded US healthcare system culture where we have implicit bias amongst our healthcare providers. What does that mean? It means that many of our healthcare providers have negative beliefs and stereotypes about race that results in them having poor communication, which results in poor care among ethnic minority populations. We also know, and this Keith has already alluded to, but we know that long-term exposure to adverse living and working conditions really sets you up for bad health. We know that in many households in poor, underserved minority communities, they're unable to socially distance even within their household. They may share one bathroom. There may be multiple families living in the same space. We know there's higher housing density. We know there are higher crime rates. We know there's poorer access to food and food deserts in these communities. And more than anything else above all that is these are the individuals that were considered necessary. Many of them are working out in public-facing jobs. So other reasons, and being an epidemiologist and being past president of the American Heart Association, who focused a lot on hypertension and comorbidities, my first thought was, well, of course we expect African Americans to have more COVID-19 and more adverse events because there are so many more comorbidities in that population. And so we know that is true, but we also know that there's a lot that we need to still do. And looking at just how we live and where we live, one example from New York City is the Bronx, which is predominantly African American, had more hospitalizations and deaths from COVID-19 compared to Manhattan, which is a more affluent and predominantly white borough of New York, despite the higher population density in Manhattan. So we know that place matters. I'm in epidemiology, person, place, and time all matter. And these are very important reasons for these disparities in COVID-19. So what are some solutions to eliminate these disparities? I think we still need to learn a lot about this particular virus. We need to make sure that there aren't any other susceptibility factors that may lead to such different COVID-19 outcomes in different individuals. Keith has already reported on the impact of age. 85% of the deaths were, I believe Keith said, were occurring in those over 80. What is it about age? Well, what is it about ethnicity? And how do we track these susceptibility factors that we may not yet know about? And I do think we have reached a tipping point of health equity in America through recent events that have raised our national conscience about the role of race in disease. But to restate my opening sentence, COVID-19 has become a magnifying glass that really has highlighted the racial and ethnic disparities in healthcare. So we need to look at root causes of these health inequities and do so with a systems approach, which public health, as you know, is really good at. We also really need to think about ways to improve access and high quality care in these under-resourced settings. So today I read that Norton Healthcare, one of the leading healthcare companies in our state, has announced that they are creating the Norton Healthcare Institute for Health Equity. And as part of Norton Healthcare's mission, their goal is to remove obstacles that prevent people in these underserved areas from getting care. And they are going to, they've already committed to spending $20 million to build convenient and geographically accessible points of care for their members. So again, this is a very important area, a very important time in our country, and it's a great time to be in public health. This is what we do, this is what we live for, and I am delighted that all of you joined today. Thank you, Martha.
Thank you, Donna Arnett. It looks, Trey and Jack, that we do have a few minutes for questions. Trey, do you have some that you'd like to tee up for our panelists?
Yes, I'll get my video going again. Hi there. There's a lot of great questions, so we'll try to get to the
I
ones
thought
that
I saw many coming in, so thank you.
This is great engagement for everybody there. So, and I'm sure that a lot of these will be for multiple panelists. So I'm going to scroll to some that I've highlighted here. Let's see. So I think there were several questions about people commenting about the areas in which they live, noticing that there's not maybe a whole lot of action being taken for wearing the masks or following some of the best practices for ensuring that we don't transmit COVID-19, as well as kind of a general sense that maybe the fear is overblown or that we're past the hump. And so this seems like a question for all panelists, but I think the spirit of all the comments that people were making is to sort of ask about your thoughts about how to counter that kind of either information or perception, and what are your thoughts on the kind of public perception or misperception?
Kathleen, can I ask you to address that? That seems like some of the work that you're doing.
Yes, though I'm not a behavioral health person, so I can't really speak to the issues around, really why people have the perceptions that they do. I think it is certainly challenging because for the most part, this is invisible to a lot of people. Most people are not directly impacted, and even just talking with my own colleagues and friends, they don't know individuals who have been infected and who have died. So there's just this sense of that the risk is not really important to them. And this is true with all public health interventions. If you don't have a perception that the risk is going to impact you directly, then it's easy for you to ignore that or not act on it. I mean, people all the time make decisions that are not good for their health and well-being. So I don't think that this is so different. But what does differ a little bit is that it's really not just about their own individual risk, but the risk to the community. And I think with mask wearing, that's really where it comes into play, because we don't think that it does a whole lot to protect that individual who's wearing the mask. But we do think that if everybody wore a mask, it would reduce spread overall, because we would protect from the source. So I think that that's one of the messages that can get out there, is that this is really something that is part of your civic duty, if you will, to help the more immunocompromised around you.
Could I add on to that, Martha?
Oh, yes, please.
I think this is an area for public health to really think through, particularly in the realm of policy. So can we mandate mask wearing? We have good scientific evidence that should be done, but can you mandate it? I know in our state government, it's been highly recommended, and we've mandated it in the workplace with specific rules about when you have to wear masks. But you're right, all of the people who are commenting on mask wearing, when you go out in public to the grocery store, to stores, there's a lot of people not adhering to mask wearing. So what role does public health play in terms of moving that needle on policy?
Thank you. Trey, next
Yes.
one.
So we have a couple of questions here about immunity. And so there's one question from Mary Sue Lindley. What information exists to indicate if immunity post-infection happens? If immunity occurs, is it short or long-term? And there's kind of a second question I'll go ahead and read with it. It's very similar, from Amanda Elmore, is there confirming evidence that infection with COVID-19 protects you from a subsequent infection? And if not, can we consider herd immunity at this point?
I can try to answer this question. So there's growing evidence that there's short-term immunity from infection, and that's consistent with what we would think just with other coronaviruses as well. What we don't know is how long that immunity would last, and if this virus will evolve and become, more resistant, or, sort of like influenza, where you can get reinfected with similar strains. So in the short term, yes, we think that people who are infected do have some immunity, but we don't know. We also don't know what level of immunity they have. So if we're doing an antibody assay, for example, there's no threshold that's known to be protective. So it's hard to interpret those data to equate that with immunity.
So we have another question. It's maybe mainly for Teresa, but for all for sure, is what have we learned? You've talked about modeling and sort of the ways that we can read models and respond to them, but based on what you've seen in the kind of public reading of the models and the public response to the models, how have we read them publicly, and what could we learn from that in the future?
Very good question. I think models can be very complex, and the public sometimes has difficulty digesting more complex explanations. And it is worth thinking about, excuse me, whether there can be a few voices with very clear messaging based on the models, rather than a lot of voices with conflicting messaging. And that's one of the things I think we've learned, is that it is very useful. In the state of Kentucky, we've had, sorry, of course, Governor Beshear has been out in front of us every day, and being both reassuring and sharing information. Other governors have taken that role. I think that's been a good model. And I think we have to be careful about putting too much stock in any one model or lots of voices.
So there's a question that just came in from Phyllis Perkins. What impact do you think the recent protests, the peaceful protests, will have on the resurgence of the virus? And I think this is a particularly interesting question, given that public health, officials have also spoken about the systemic racism itself as a public health crisis. So just your thoughts on kind of the ways that these the protests can maybe have an impact on either resurgence or not.
So we know from the most recent evidence that being within 6 feet of someone who is infected and shedding virus for more than 15 minutes is typically what leads to infection. Before we thought it was 30 minutes. Now the new recommendations today are 15 minutes. So, and we also know that yelling in particular, singing loudly, both of those are associated with more virus spread. So both of these are associated with demonstrations and protesting potentially, because you're closer to individuals. If you wear masks and the other person wears a mask, then you are more protected, not completely protected, but more protected. But there's no doubt from my perspective, I'd be interested to hear what Kathleen thinks, that this is going to lead to more cases.
Yeah, I agree. I mean, these are outdoor exposures, so they are likely to be lower risk. But if you have people not social distancing, gathering for any reason at all, then you're likely to see increased risk of transmission. I will say we haven't yet seen evidence of that locally. We are seeing increasing cases here in Fayette County in the last several weeks, but nothing that suggests that the protests are a driver of that. Though it, as it continues over time, we may see increased transmission due to that.
Trey, should we do one more question? I know we're getting close to the 5 o'clock hour, but maybe one more?
We can do one more. So this is from Jim Brannon. It's a question that says, some folks have sought to understate the severity of the pandemic by claiming that deaths are unnecessarily listing COVID-19 as a cause of death when other comorbidities were more prominent. Can you give us some guidance on what is actually listed or otherwise in terms of a cause of death? I guess the question is asking about, the claim that the deaths by COVID-19 are either accurate or not based on other comorbidities.
Can I take
Teresa?
a shot at that, because that's kind of data related? There's really no evidence that that's true. In general, to be labeled as COVID-19 death, there had to be a positive COVID test. And in addition, so in all likelihood, we are undercounting how many folks are dying from COVID-19 because we know some people have not been tested or it's not reflected. In addition, we have such a heterogeneous way of, especially in Kentucky, of labeling something as a COVID-19 death that also lends itself to undercounting, not overcounting.
Okay, thank you. I know, Jack, that we advertised that we will end at 5, so I want to thank you again. Thank Trey again for making this series possible. I want to thank my 4 colleagues for excellent presentations of examples of how public health is really working on the front lines and making a difference in real world issues in real time. And I'm just so glad that you all committed this time, and I really, really appreciate it. And thanks to all who are on the line and are listening today. We thank you for your interest. Jack, I think you have an announcement about the next session.
Sure, just a quick announcement. And again, I echo Martha, thank you to you and all the panelists and to Trey for your participation, and see Donna Arnett, Dr. Knapp are modeling good behavior, good public health behavior. Appreciate that. Yeah, just want to, and certainly appreciate all the attendees who participated today. Next week we have another webinar that we're going to bring to you, and it is next Thursday, June the 25th, and we're really excited about this one as well. It's entitled College Sports and Campus Crises, a Legacy of Service and Adaptation. So information is on our website, the alumni website. Some emails will go out probably tomorrow to promote it specifically, but you can go ahead and register for that if you go to our website and or look for the email, look for some of the social media information about that. So that'll include Dr. John Thielen, who's a great teacher, very highly recognized faculty member on higher education and with a background in athletics. Mitch Barnhart, our athletic director, will participate along with Jim Host. Leah Edmonds, who is a former student athlete, and Dr. Joseph Fink, who is a professor, I believe, of pharmacy at UK, but has served on various SEC and NCAA committees over the years. So should be interesting, given some of the announcements about start of fall sports and how colleges and universities have dealt with those kinds of or similar crises in the past, and just their thoughts on what the path forward might look like. So again, thank you to everyone, panelists, attendees, for joining us, and everyone have a great evening. Thank you again. Take care. Bye-bye.